So today we will have a short presentation on hand, foot, and mouth and herpangina, which is pretty common in outpatient pediatric clinics. You see it very frequently, and so this should be a pretty short and basic presentation for this. So typically parents will come in and the chief complaint will often be a rash. When you're gathering your history, oftentimes parents will state that the child had a fever prior to the rash developing, so often a day or two prior, child will have had a fever. Parents will note that the fever breaks, and then after the fever breaks, usually the next day, they will start to notice a rash. The rash can be extremely variable. It can be found on on the hands, on the feet, the diaper area, the surrounding mouth area. It can be on the arms, the legs, the abdomen. It can also be localized to just inside of the mouth, along the inside of the cheeks, or the tongue, or the posterior pharynx. So rash is super variable with it. Usually the fever is already done with because it's prodromal. Kids will have decreased appetite, they'll be super fussy. Sometimes kids will often have cold symptoms associated with it, like a runny nose, a cough, congestion. And many times these kiddos are enrolled in daycare or have been exposed to hand, foot, and mouth through a daycare or school setting. All right, so on physical examination, you will see quite, like I said, variable lesions to the body. You will see vesicular lesions. Sometimes you'll see red maculopapular lesions. You'll see it on the palms of the hands, the bottom and tops of the feet, the surrounding mouth area, the buttocks, the genitals, the diaper area, sometimes to the entire body. It's extremely variable. With herpangina specifically, usually those lesions are just localized to the inside of the mouth. So you'll see them on the tongue, the buccal mucosa, in the posterior pharynx, and that's typically just for herpangina. For hand, foot, and mouth, you'll see the rash to other parts of the body, like the feet, the hands, the abdomen, the diaper area, etc. So they're all caused by the same virus, which we'll get into here in a second, but that's kind of how you'll differentiate between hand, foot, and mouth and herpangina. In the inside of the mouth, you'll see often ulcer lesions. So, what causes hand, foot, mouth, and herpangina? It is all caused by the Coxsackie virus. And with that, there are many serotypes that cause different presentation. So there are strict serotypes that cause just herpangina, which are just the lesions on the inside of the mouth, like we discussed earlier. And then there are other serotypes that cause the diffuse rash to the body, to the hands, to the feet, to the diaper area. So but again, it's all caused by the Coxsackie virus. Incubation is typically 2 to 7 days in length, and this virus is spread through fecal-oral route as well as contact with oral and respiratory secretions. So you've done your history, you've done your physical exam, and now you're going to make your diagnosis. Personally, for me, especially when I saw just lesions or redness to the back of the throat and the child did not have a rash to their body and it was just localized to the inside of the mouth area, when I was new, I wanted to make sure that I ruled out strep. Now, obviously, as I'm seasoned, I can tell the difference between whether there's a concern for strep or whether it's Coxsackie. So I often don't need to, order a strep test. But in the beginning, when I didn't have as much, clinical experience under my belt, I would often order a point of care strep test, which obviously was negative. So the diagnosis for hand, foot, mouth, and or herpangina is made clinically based on your history and physical exam. Some differentials that you want to keep in mind are varicella, insect bites, some types of eczema, strep throat, of course, gingivostomatitis, and canker sores. Treatment. So in terms of prescribing medication, I really don't prescribe anything for this. I usually provide a lot of education on how to treat the symptoms. I have seen some providers that will prescribe magic mouthwash, which is equal parts Maalox, viscous lidocaine, and Benadryl. Typically, obviously, just to older kids who are experiencing severe mouth pain, but I personally have never prescribed magic mouthwash for this. So treatment is really trying to make sure that you are preventing dehydration. So encouraging adequate hydration through Pedialyte, sports drinks, water, popsicles, and avoiding spicy or citrus foods or a lot of acidic fluids and foods, which can often irritate the mouth, especially if the lesions are in the mouth. I often will recommend dose appropriate Tylenol or Motrin as needed for comfort. And I often will not recommend any topicals for the rash as it's self-limiting. Education that I provide specifically to my parents is that the rash can last, at least 7 to 21 days. And with that, often you will see shedding of the skin as well as sometimes, especially in the younger kiddos with certain stereotypes of the Coxsackie virus, their nails will fall off. I like to warn my parents of this so that they are not completely disturbed in several weeks calling and worried about why their kids' nails are falling off. So that is something that I like to touch on with my parents. Another thing that I, really, really try to hone in on is preventing dehydration. And a lot of times I'll have parents who will tell me that their kids aren't drinking anything, they're refusing to drink their sippy cup. And with those kids, I will actually recommend using either just like a tablespoon or a teaspoon and, giving their child a tablespoon or a teaspoon of Pedialyte every couple minutes. So instead of giving that child a large sippy cup full of a fluid, which could be very daunting for a kiddo who's just super fussy and irritable, then with those kids, that's where I recommend, every 3 to 5 minutes, give them a teaspoon or a tablespoon of Pedialyte. And that's how you can ensure that they're, staying hydrated. For younger kids, I definitely recommend counting the number of wet diapers so that you can gauge how their urine output is, which is directly correlated with their hydration level. Any fever that'll last more than 5 days, I often will tell my parents to call the clinic so that we can have a discussion as to whether they need to come back into the clinic for further evaluation. And in terms of like after hours outside of the clinic or unable to contact the clinic for help, reasons or indications you'd want to bring your child to the emergency department would be extremely severe dehydration, complete refusal to drink any fluids, lethargy, those type of things. I often don't recommend any type of follow-up after this diagnosis is made unless I do have concerns for a child who may get dehydrated, but isn't to the point where they need to go to the emergency department that day. So with those kids, I'll have them come back a day or two afterward just to, make sure that their vitals are stable and that they're hydrated appropriately. And then if at that point we have concerns, then we can proceed forward with admission or going to the emergency department, which is pretty rare. So biggest takeaway with education is prevent dehydration and encourage lots of hydration. These are some patient handouts that I will give my parents when the diagnosis of hand, foot, and mouth or herpangina is made, especially the first link. A lot of parents just have, some questions, so that is a really good resource for them. And then some dosage sheets for Tylenol and ibuprofen. And then my references are based, of course, on my clinical experience as well as up to date. So that is herpangina and hand, foot, and mouth in a nutshell. I hope you found this helpful and let me know if you have any questions. Soon I will be coming out with another, guide for another common illness. So hope you have a great day and take care.